Welcome all. I'm Adelina Comaz-Herrera from the London School of Economics and the director of the Global Observatory for Long-Term Care. I'll just give a very brief introduction to the observatory, and then I'll hand over to Igor Shigalov and the speakers for today. The Global Observatory of Long-Term Care is a platform for cross-national learning on long-term care. The idea is that we've learned from the pandemic that there are key shared long-term care challenges that many countries are all countries are facing, and we want to facilitate learning across by sharing evidence and facilitate collaborations. This platform is available to everyone, from policymakers, industry, advocates, care professionals, academics, and it's part of the International Long-Term Care Policy Network. To engage with the observatory, the most important thing to do is to create a profile and become a member, and then you can choose which of the interest groups you'd like to share, to be part of. And you can also share with us relevant publications and events. You can subscribe to the newsletter, and you can also make suggestions about how you'd like the observatory to be shaped. We have a few more webinars lined up. The next one after this one is organized with the WHO Regional Office for Europe and the European Commission. And this is looking at an assessment tool for long-term care systems, and we'll be looking at how it's been implemented and piloted in Ireland and Greece. Then we will have a meeting of the Spanish long-term care interest group, which will be in Spanish on the 15th of July. And we will have one from the experimental methods group on the 23rd of July on institutional versus home-based long-term care, with a presentation from Katia Nicodemo from Austria, from Oxford and Verona. And we then have a webinar. We don't have the full details yet, but we know the date is the 17th of September from the pain assessment in long-term care interest group. So that's it from me, and I'd like to hand over to Igor, who's the lead of the Care Homes Regulation Interest Group.
Yeah, I hope everybody see my slides. So yeah, dear colleagues, I'm pleased to welcome you to the second webinar of the Care Home Markets and Regulation Interest Group of Global Observatory of Long-Term Care. Thank you very much for joining us. And as you know, my name is Igor Shigalov, and I'm the group lead. And if I may, I would like to say a few words about our group. So the aim of our group is to support knowledge exchange about regulatory and market shaping policies to improve the quality and outcomes of bed-based care by open collaboration between academics, policymakers, practitioners, and providers. In doing so, we pay special attention to the potential and limitation of different ways of organizing care markets and their impact on care outcomes and costs. And to this end, the group will organize regular webinars to share relevant evidence and create a platform to live discussion among international experts. So, however, we don't limit ourselves to this. We endeavor to disseminate the knowledge gained from the group's work beyond its boundaries. And our group will be happy to post your publications and other materials relating to various aspects of care homes and regulation. So how can you do this and keep up to date with the group? It is very simple. There are only 3 simple steps to do this. So the first step is to register on the observatory website, and the link can be seen on the screen. The second step is to tick the box for our group during registration. And finally, the optional third step, if you already registered on the observatory website and would like to join us, you can simply fill out the application form on the group page itself. And that's it. And of course, we look forward to having new members in our group, and you can also send us any questions or concern about the work of the group and participation in it to the emails which presented below. Now, a few words about the composition of the steering group. It includes José Luis Fernandez, the Director of Care Policy and Evaluation Center, Adelina Comaz-Herrera, Assistant Professorial Research Fellow, Care Policy and Evaluation Center, and I, Igor Shigalov, Research Associate, also Care Policy and Evaluation Center, and the Research Fellow at the University of Birmingham. Now let me say a little about the topic of our today's webinar. Today we would like to continue our group's work with a series of few webinars, which topic has become the most visible and tragic in modern history, the coronavirus pandemic. And we could pass it by because of its significance and impact on the care home industry around the world. And it became an exogenous shock to the care industry, which made its drawbacks visible for all of us. And more than 3 years after its onset, a huge amount of data, many studies and publications have accumulated. And we think it's very important to talk about the lessons of the pandemic for the care home industry, and especially how we can improve existing long-term care policies to make the life better for all the people in care homes. And we are very pleased that Marina Nistotskaya and Rasmus Broms from the University of Gothenburg have agreed to present their paper today on the lessons of the pandemic in Swedish care homes. But before I turn the floor over to our distinguished speakers, I would also like to say that we would appreciate it if you could share with us your ideas for future webinar topics that would be interested in considering. And you can do that in the chat during the webinar or by email presented below. Now, Marina and Rasmus, please, the floor is yours.
First of all, many thanks for inviting us, and we are very happy to represent our small group, Rasmus and I, our small group of researchers. We are 3 political scientists from the same university and the same department, and Jena Nayer is a medical doctor here also at the University of Gothenburg. So I know especially in the UK, politicians, policymakers and citizens look up at Sweden as something good. Copying school system and other things, low levels of corruption for the rest of the world. And unfortunately, Sweden made the global headlines in the beginning of the coronavirus pandemic for a wrong reason. You can see the an example of, I think it's one of them is BBC and another is CNN. So COVID in Sweden, elderly people deserve more, or coronavirus, what's going wrong in Sweden's care home. And so what went wrong? About 40% of all the deceased from the COVID-19 in the year 2020, so that is before the vaccination kicked in, they lived in long-term care facilities, in nursing homes. So 5% of individuals who resided in nursing homes, they died. But there is also large variation in death and the infection rates, I must say as well, across nursing homes. Yeah, so this is the a stylized map of Sweden on the left, with the darker shades of gray representing higher death rates, and then lighter shades low levels. And also you can see the distribution, it's quite skewed. So but anyway, the percentage of share up to 5%, it's quite a densely distributed. So the question that we are asking in this paper is why individuals in some nursing homes were at higher risk of dying from COVID-19 than in others. And we are talking about the period from the beginning of pandemic in 2020 until the end of the year, again when the vaccination, mass vaccination started. If you look at the previous research, of course, there are like 2 types of literature. One looks at the service quality in nursing homes broadly, and this is like a mother literature within which the literature on COVID outcomes is nested. As I think at least this is how we understand it. And if you look at this broader literature, then we can see that when it comes to the ownership, there is pretty much a consensus that for-profit providers underperform in terms of the service quality. But when it comes to the outcomes, it's a mixed picture, both with regard to the infection and death rates. Another usual suspect within this literature is staffing indicators. There is, again, when it comes to the broad service quality, again, for-profits underperform, and there is also a kind of consensus in the literature. I think on staffing indicators, it's even stronger than in terms of ownership type. But when it comes to COVID outcomes, at least at the moment when we conducted the literature review, I know that the literature has grown rapidly since, so you might correct us on this, but the picture was mixed. And then we have facility size and design. And here is the arguments pro and against larger facilities. So larger facilities can induce higher infection rates, but it is also, they might be better in organizing the zoning of the both personnel and the residents of nursing homes. It's still less clear what is the relationship between the facility side and COVID-19 attributable deaths. Facility design, very interesting line of research, but too few studies to make any kind of takeaway, and also very difficult to measure, to be honest. So when we assess the literature, what we kind of saw, it's predominantly facility level data only, right? So the data on the facility level without individual level data. Very few nationwide studies, mostly kind of regions, and a lot based on the US data. So there are also interesting modeling choices, let me put it this way. Specifically, ownership is predominantly treated as an ordinary predictor, so in line with the staffing characteristics or facility size. However, some scholars implicitly suggested that ownership is the first order predictor that in turn affects staffing quality, for staffing characteristics, for example, or the design of the facilities. Thus, for example, research from the UK context points to this. And also, it is not kind of a universal measurement of ownership, that it's binary, but still, predominantly the discourse in the literature is about private versus public versus private, without distinguishing different types of private forms of ownership. And we try to overcome this kind of limitations in the literature. First, we were thinking about ownership explicitly as the first order predictor that affects, we focused on the mortality from COVID-19 as an outcome variable. So ownership time, as you can see, affects mortality via personnel characteristics and the facility design, specifically type, the size of the facility. But it also could be other effects, which we just kind of assume to be direct effects. So this is first thing that we try to kind of to offer with this paper. Secondly, we basically looking at the empirical variation in the non-public ownership in Sweden. We suggest that we can look at for-profit providers that are either publicly traded or private limited companies, so they are not traded on exchange, stock exchange is not traded, and also non-profits, which are a private form but not for profit. We also think that if we, with this data from Sweden, we can offer a new setting. It's mature welfare state, and bring kind of into the mix new type of evidence from a new setting. It's a nationwide study. We cover, as you will see, almost all the population and all facilities in the country. And the particular pride of kind of this paper is that we use individual level data that are nested in the facility level data, and plus we also control for municipal or region fixed effects, proxying for different political and geographical factors. So a little bit about the organization of elder care in Sweden. It is a responsibility of the Swedish municipalities. There are 290 municipalities, and the municipality can either run a nursing home itself or buy the service on the market or outsource the existing facility to the market, to the private entrepreneur. Non-public providers operate in about a third of the municipalities, and nationally the ratio of care home residents living in privately run facilities is about 1 in 5. So every fifth lives in a privately run facility. So when it comes to the data, we use data on all individuals who were it's an interesting characterization. Who were residing in a nursing home, at least they had a decision of the authority to have a place. We don't know whether they were there, but once you have a decision, it is very likely that you will be living in the nursing home. It is coming from a very high quality government registry. So that is the big plus of this paper, is that we are drawing on a really high quality registry data of the different Swedish authorities. So this individual level data is nested within the nursing homes, which are about 2,100. And we draw the information about nursing homes from several sources, including Statistics Sweden Business Registry. And it's also, there is this government data set, which is database, which is called Longitudinal Integrated Database on Health Insurance, LISA. And it has a lot of information on providers, different kind of healthcare providers. So, for example, information on the type of personnel, what kind of nurses are they, how they're employed, the employment conditions, and etc. are taken from this LISA data set. Then we have some data on municipalities, and then we have some data on regions. So we control for this through actually fixed effects. Our time frame, as I said, before the vaccination kicked in. So the main problem that we grappled in this paper is that despite all this good information, this information is not matched. So it exists and sits in different registries, and that is what Rasmus mostly, not only that, mostly done out of 4 authors on this particular issue. So the solution was we matched through addresses. First is the addresses on individuals, again from a very high quality government population registry. In Sweden, you have to get registered when you change the place of residence. And this updates, this database is updated as we speak. And facilities, we use the visiting addresses of facilities, so that when it's matched, then we would say we would use this data. We managed to match data on 62% of all the individuals with this decision to be granted the nursing home residency, and 2,084 facilities, so almost every facility we were able to cover in the analysis. The geographical distribution is relatively even, and the low matching rates were observed for newcomers, so these people who got this decision more recently. Again, there is some suspicion that maybe they didn't make it quite to the nursing homes due to the pandemic. And also, strangely enough, individuals with partner. So what we are looking at specifically, we are looking at ownership type, and as I said, we distinguish between public, two types of for-profit listed company or non-listed company, and non-profit organizations. And then when it comes to staffing and size, we take this data from Lisa. We look at the number of residents, number of care staff employed full year as a share of the total staff, care staff with other employment as a share, nurse, whether there is a nurse employed at this facility or not, and whether there is a manager employed at the facility. Why there is a nurse, whether there is a nurse employed at the facility, this is a very interesting feature of the Swedish kind of devolution of authority between different levels. So healthcare is a responsibility of regions, which is a higher level than municipalities, and that is why healthcare providers are not available kind of all the time at the facility level. So if they need healthcare provider, they either ring the hospital or the medical staff visits the facility. So there is there is a permanent medical personnel at the facility. It's not a standard in Sweden. And of course, we look at the COVID-19 attributable death as our outcome variable, which is also from a government registry. So we run two types of analysis. First, we look at the ownership type and the size staffing characteristics. Here we only employed facility level data, and we run OLS and logistic regression with regional fixed effects. And in the second step, we leverage all the variables, ownership, type, size, staffing, and against the risk of death from COVID-19. Here's the primary data individual. We use Cox regression with regional fixed effects and individual controlling for the individual level data like comorbidities and also demographic data on residents like gender, age, birth region, which basically controls for whether it is someone who was born in Sweden or someone else, somewhere else, and education. So what we find in the first result, in the first type of analysis, we find that public facilities are associated with lower turnover of care staff, lower share of personnel with second job, and less often employ the public facilities less often employ nurses at nursing homes. In the second step, when we assess the risk of dying from COVID, we find no difference between ownership type once we account for the regional fixed effect, and no difference in staff density. However, there is a higher risk of death for larger facility and facilities with higher care staff turnover, and lower risk of death when there is a nurse employed at the facility, which is normally for-profit providers. So overall, we find that the facility level factors are secondary, less important compared to geography and the individual level factor. And geography is basically determines the density of the community spread of the coronavirus. So to kind of check our findings, whether they are robust, whether they are stable, we perform the following exercise. We have external data from Stockholm. It's the largest municipality, and it's a hotbed of for-profit ownership. About 90, a lot of for-profit nursing homes are concentrated in the greater Stockholm. And here the match rate between individuals and nursing home was quite high, 93%. So, and then we also used our own data with some samples with higher matching rates. For example, singles or no newcomers, singles only or no newcomers. Overall, these robustness exercises didn't introduce much changes in the results. So what we can conclude from here? So it's a first nationwide study with individual and facility level data combined. It's a high quality registry data. We kind of employ implicit theoretical model of direct and indirect effect of ownership type. And our main takeaways is ownership type doesn't make, at least didn't make much difference in the first wave of coronavirus for the residents of nursing homes. To much upset of many people who expected something else. And there is lower risk that is associated with both public and private types of ownership. For example, low staff turnover, which is associated with the public providers, and also low risk for dying comes from a nurse being employed at the facility, and this is associated with private providers. So perhaps some management level factors are at play here, which is we are thinking as avenues for further research. Yes, so we need to acknowledge our funders, and also this paper is now published in and it's available for everyone. Thank you, and we are happy to take questions.
Thank you very much, Marina. Excellent paper. I'm José Luis Fernández, and I'm going to be chairing the questions. And there's already a couple of comments and questions in the chat. So why don't we start with that? So Olena, do you want to ask your question and perhaps just very briefly introduce who you are before you do so?
Thank you very much for presentation. It's very interesting. I'm thinking when you put regional level controls, and you mentioned at the beginning that regions decide how the care would be provided. Would it be publicly provided, or would it be privately provided, outsourced, etc.? And then you said when you control for region, you don't find the effect of ownership. So I'm here a little bit like, what's the interpretation then of the variable? Wouldn't you just expect this because the decision is made? So basically the region, the type of region, the kind of region determines what kind of ownership will there be. Thank you.
Okay. And just before you answer, Marina and Rasmus, so Olena is a researcher at PSI.
Oh, sorry, yeah.
That's okay, that's okay.
Sorry, Luis, thank you.
No, I mean, it's a good question, but I probably was not, it's down to me that I was not clear. So within each municipality, there is a variation in terms of, so there are both, you can find nursing homes both in private and public hands. So it's not that one municipality decided to privatize or outsource and everything is outsourced. It's a mix. So that is why controlling for the municipal level does not control for the ownership, right? So our variable ownership type is at the facility level, not at the municipal level. Right. So municipal and regional fixed effects, they control for other things.
Why do you think then the effect becomes not significant when you go for the region controls?
Because it is the spread of the coronavirus. So
Okay.
there were hotbeds. This is what we believe. So again, we have two types of fixed effects: municipal fixed effects and regional fixed effects. It's when we are going for the regional fixed effects. So when you have conglomerates like Stockholm, Göteborg, Malmö, what else? Did I miss something?
No, I think in terms of, I mean, that's, you know, the more metropolitan areas are generally where
Yes.
where the spread of coronavirus was the largest, I think, which is, I mean, maybe not a completely universal trend, but quite common, right? And these are also the places where private care in general in Sweden is more popular.
Thank
Okay.
you.
So I
Thank
think that's
you.
the main confounder that we, you know, wanted to kind of partial out using our strategy, using the regional fixed effects.
Sure. Okay, thank you very much. So the next question is from Sam Rickman.
Hiya, I'm Sam Rickman, a researcher at CPEC. Yeah, my question was about that really. I wasn't, maybe I missed it, but I wasn't entirely sure what all of the things that were included in the region level fixed effects and whether it included the infection rate and if it of the area and if it did what area of the general population, I mean, rather than of people in care homes.
Rasmus, do you want to?
Yeah, sure. I mean, this is our approach after kind of, you know, thinking a little bit about, you know, how best to kind of do some sort of like a moderately parsimonious design here. We kind of decided on just like doing the hammer here, basically saying that yes, we know that there are a bunch of regional variation here, and we are not really interested in that. So that's, you know, why we went for this kind of, you know, I mean, doing the stratum approach here. You could discuss, and people, you know, we have been engaging in discussion with us about which level to kind of mainly focus on. We landed on the regional level, which is, you know, kind of a slightly higher level than the municipal level. But we also provide those results in the appendix. But the reason for that was that basically we, you know, a region in Sweden is not huge. It's not like a, you know, as a German state or something like that. So we were kind of, you know, afraid that we would kind of by including too low level fixed effects, basically we would kind of, you know, generate false negative results. So we kind of landed on this compromise, which is just like say that everything that is on the regional level is kind of out of play, and everything that goes on within it is something that we consider to be relevant variation.
Right. Okay. So sorry, because when I said regional, I wasn't really distinguishing between the region and the other level, municipality. Is that what you called it?
Right.
So did you include the general population mortality rate at municipality level, or was it just not included in the model at all? That's what I'm wondering.
Right, great question. I don't think we did any models with the general. I don't think we did any like
We didn't,
level
no.
controls. No.
I was just wondering because I mean,
yeah.
obviously, you know, it's an infectious disease, so you would think that might, I mean, it might not change the results. Maybe it's all picked up in the random effects at the facility level. So, I thought maybe that would be an interesting
Right.
robustness test to see whether it was different.
No, that's a good point.
But it's also, I mean, in Sweden, the level of spread in the population was very regionally, has very clear regional patterns. That is why at the moment when we were doing the paper, there was no reliable statistics for the entire population. So we decided that it will be like a reasonable proxy, you know, among other things.
Yeah, that makes sense.
Thanks. For the region.
Thanks.
Thank you very much. Okay, so over to Aida Suarez Gonzalez.
Hi, everybody. Sorry, I cannot start my video. Thank you very much for a fantastic presentation, and thank you, Adelina, and the rest of the team for organizing these webinars. They are fantastic. So my question is about ownership, and as you were displaying your slides and showing these discrepancies about ownership and whether the private sector does better than the public one or not, I wonder whether part of that contradictory data from different studies may lay in the fact that perhaps different countries commission private services when it comes to the long-term sector in different ways. And I don't know if this is the case, so that's why I'm asking whether some countries may be more strict with how they commission those services, and other countries being more lenient, and perhaps this even depending on how burning the needs to cover services are in some countries compared to others, because I know that demographic pressure is not the same in different countries. And I was also thinking about whether some governments may be more tolerant with aggressive investors, to put it in clear words, while other governments are more protective of the services that they are offering to the population, and they are far more strict with private companies providing long-term care. What are your thoughts about this?
I think it's a wonderful question, and in all honesty, my answer to this would be we don't know, but I suspect that there is something going on here, including what you rightly highlighted, different results for the private sector. That it's what private sector means in different countries. It's a different thing. For example, in Sweden, it is not privatization, right? It's only the facilities are outsourced for a certain period of time. The private company run the facility for a certain period of time, but the facility is still owned by the municipality, right? So there are also private facilities that are built, maintained by the private sector, but there are very few. So when we are talking about private run, that is why we use privately run facilities, right? It's still very different than, for example, right, outright privately run facilities. So I think I haven't seen a study which goes into detail and actually leveraging these different, what does it mean to be public and also or private, and also the level of kind of quality control that the government has over the private providers. I think it's an excellent question, and one obvious avenue for future research.
Adelina, I think you've asked a question there. Do you want to?
Yeah, it's a bit related. I was wondering, why is it that the private for-profit sector does have nurses, and is it that's their initiative to do that, and they do it to distinguish themselves or to offer something better, or is it a regulatory requirement that they do so? Because I'm curious, like in other countries, the private sector offers less qualified personnel, whereas in Sweden seems to be the other way.
I think we thought about this a lot as well, and I think coming from the field of like political science and public administration, we definitely learned a lot about these granular management and organizational aspects of it, like how Swedish elder care facilities are set up. But this was kind of something that we had to look for, and I think the simplest answer for this is basically economies of scale. Basically that. When private operators have a set up a facility, they may not have a bunch of other facilities in the immediate vicinity, so that a nurse can kind of have access to the clients. Whereas in a municipal setting, there might be enough with like maybe one or two in the municipality, but and they may not be actually hired at the facility level, which and I think in an everyday setting that might be efficient and good, but it seems like in the case of a pandemic, it might not be as good, at least if we judging from our results.
And I have a question.
Okay, go for it.
Is there
look, if on that, can we let Kai come in, because
yeah, I see
comment is
really
exactly on this.
Yeah. Kai, go. Yeah.
Yeah, okay. Yeah, welcome. Hi.
Sorry, can you introduce yourself?
Yeah, I'm Kai Leixning, European Center for Social Welfare Policy and Research. And I did some studies about privatization and also this new public management also in Sweden. And I found it always sympathetic that there is no actually no clear definition of staff levels, and still staff levels are higher than, for example, in Austria, and I think also in other countries. And also this idea to not have medical staff in a care home to avoid the medical model. In the end, I think this didn't really work out, but still, during the pandemic, this obviously clearly backfired, and is especially also by the spreading when nurses then served in different care homes. Is this right? And if yes, was there any learning from this?
I don't know if Marina, said something about this. I just think that what we see is kind of in line with what you think. We didn't actually follow nurses that were we couldn't see where they were tasked with working, for example. So we couldn't do that type of network analysis, unfortunately, although that would be fascinating. But I mean, our results are in line with your hypothesis, so we at least don't refute it. I guess is what I could say at this level. But Marina, I don't know if you have.
But was there a learning that so in the future there should be nurses in care homes and employed?
First of all, I wanted to say that we were ourselves surprised by this finding about the nurse and wanted to continue it, but didn't get funding. So that kind of at the moment died. But whether there is a learning, I think there is a, Sweden is going its own way. It's going through the massive commission of inquiry into it's already, by the way, had a commission of inquiry into the government management of pandemic, where the nursing homes was a big part of that report, and we also provided some input to that commission. And now the government is going through this, discrepancy between that the health services provided at the regional level and the other social services are provided at the municipal level, and so they are considering different types of kind of reorganization. This is one of the types, but this is I also know that there is a kind of low level response to this, like on behalf of I know my colleague Ulrika Winsblad conducted the research whether the nursing homes themselves learn from that having a nurse is a solution, was at least a positive factor during the pandemic, and we do see that they are. There is more nurses employed by the even private providers, public providers right now, but it's also not published work, and so it's all in the flux. I think something is happening, but the answer hasn't materialized yet.
Thank you very much. Okay, so we've got a question by Greg Harling, and then Leonid, I'll give you the next question. Greg, do you want to ask your question and introduce yourself?
Yes, I'm Greg Arling. I'm at Purdue University in the U.S. And it strikes me that this question really is a multi-level effects question. The likelihood that a resident will die of a COVID-related death within a particular facility context. And then you have the local or regional effects as well. And in the work that we've done, there's quite a bit of variation in what appears to be the local outbreak effects. And I think it's an interesting question. In localities where you have local outbreaks, how much variability do you have in death rates? So it's kind of this interaction between the different levels of effects. I think I wasn't quite sure about the Cox regression modeling that you did, but when you bring in the fixed effects, when you treat region or this level as a fixed effect, you basically lose information about that level. So I'm wondering, a multi-level modeling approach, I know it's complicated, particularly when you get to three levels, but you can also stage it and do it, 2 levels at a time. But that might be a little more productive in terms of disentangling the effects that are occurring. And it's a very complex situation. I think that's one of the reasons why we haven't been able to find distinct patterns in any of the countries that have done the analyses, which you pointed out in your literature review. So anyway, those are my comments on the analysis. Overall, I thought it was a really great paper, and also learning about the nuances of the Swedish system and how that relates. I think it's really quite interesting.
I think, Rasmus, it's your domain about the multi-level.
Yeah, sure. I mean, thanks for that comment. I think it's an eternal, I guess, debate between this hammer, still again, like the hammer versus the scalpel approach, and how you model these things. And I agree with basically everything you said there, that everything, doing this kind of like multi-level modeling with cross-level effects would certainly, maybe give some more nuance to our results. However, like the route that we went on here was kind of like based on this very kind of specific hypothesis, which already were quite a bit, quite a few different ones, since we didn't only want to focus on ownership type and not only on staffing, but I mean, given that we didn't have any, a priori hypothesis about these kind of, differential effects that you're talking about, we kind of opted for simplicity here, and then we felt like this kind of removing the exogenous to us variation was more productive, but not to say that what you're talking about wouldn't be interesting. I don't have the specific hypothesis to from theory, but I'm sure that they're out there. So yeah, thanks.
Thank you very much. Leonid, do you want to ask a question and introduce yourself?
Thank you. Good afternoon. Leonid Polishuk, Indiana University, and Marina and Rasmus, it's very good to see you again. We met a few years ago at your school. I have a question that was not brought up in your presentation. Sweden was unique among developed nations in its permissive attitude to COVID restrictions. You enforced almost no restrictions on contacts, mobility, social distancing, so on and so forth. And at that time, Sweden was criticized for sacrificing its elderly, but later on there was some evidence that excessive restrictions turned out to be counterproductive, including restrictions in nursing homes, and they might work to restrict the spread of the infection, but they had an adverse impact on mental health and physical health of residents because they were denied social communication, connections, so on and so forth. I'm wondering if you have something to say on that matter, and in particular because the Swedish government apparently did not mandate any blanket restrictions across the country. There was some variation across Swedish nursing homes in imposing local restrictions on their own. Maybe that would give you an opportunity to see if these restrictions were helpful or counterproductive or whatnot. So if you can comment on this matter, that would be great.
Yeah, I mean, you are right. Just to begin, Rasmus, I don't know whether, so good question. What are we look at the very short term, and again, right? So when we saw the highest rate of death, which dramatically reduced due to number of factors. But our focus was on this first period. To what extent, I mean, I am not sure that this individual restrictions were such a universal measure. Rasmus, do you know, by nursing homes, I just do not know to what extent they were practiced, by what is the share of nursing homes actually introduced these restrictions. I don't know this data, and I didn't come across it, to be honest.
Anecdotally, it was common, I think. It was, the way it was portrayed was that this was, they tried to maintain bubbles, basically.
Yes.
Maybe not successful enough, for sure, but.
So that was not that easy to incorporate. And then again, it's a great question. What is the long-term effects? What looked like, again, a dreadful, right, approach of the government perhaps turn out in comparative terms not so bad if we take at a longer period. But again, we simply don't have enough data, and didn't pursue in this direction.
Thank you. That links to a question from Igor about the longitudinal effects or differences.
Yeah, thank you very much, Luis, and thank you very much, Rasmus and Marina, for the fascinating presentation. Perhaps my question is beyond the scope of your study, but nevertheless, considering the study covers the year 2020, have you observed any changes in the association between long-term care facility characteristics and COVID-19 mortality in subsequent years?
I mean, I know definitely that the mortality was not as high. So, like in the 2021 and 2022, there was not even close. So, in the first year, there was 5% of all residents who died. It was not even close to like 0.5% later on, COVID attributable deaths. But the difference in the characteristics, to model this with the vaccination rates and how they unfolded, it became a little bit more, not more a little bit, but much more difficult. So we haven't pursued this line, and I haven't seen studies about this. So.
Yeah, I could just add that we did kind of hang at the door at like the data that came in from Central Statistics Sweden, basically. So even though now it's like Asia's history in a sense, studying only the beginning of the pandemic, but yes, we were kind of limited there, and we were kind of, I think, fortunate in a sense that the vaccinations began right at the end of the year, and that's kind of the scope conditions of our study, basically saying that this applies to pre-vaccine context. However, I would say like a natural, interesting thing that this group might know a lot more about than we do is the vaccination rates in themselves as like a kind of a quality indicator here would be interesting, not just as a context, but the private or which type of facilities manage to get the rollout of vaccines faster would be very, very, very interesting to know more about, I think.
Definitely. Okay, we've got a couple of minutes left, so I'm going to sneak in one question myself. One of the factors that will be driving differentials in mortality is going to be the characteristics of individuals, the residents, and those could vary between types of facilities. You haven't got the sort of the health profile of individuals or their disability, or do you? And if so, have you controlled for that? Because I didn't see that in the slides.
I think Rasmus is also assumption that there was one of the reviewers' questions, so we did conduct a special kind of exercise about this.
Yes, and well, here we would really like to kind of pass the ball over to one of our co-authors, Jenna Najjar, who's a geriatrician, I think is the word, and we worked a lot with her because she's an expert on this type of thing. So we had a bunch of comorbidity data, which is one of the advantages of this type of register data. So I'm not gonna just get you the list, but age, for example, is something that we of course account for. Gender, things like cardiovascular disease, dementia, very important, of course, and also some, but not a full range, I would say, of socioeconomic variables. But for example, like a completed education rate, the highest level of education completed, and also the region of birth. So I would say that, yeah, you could, you get into the minutiae of which, factors to control for, but I think we have a relatively extensive set of controls at the individual level here as well. But a great question. Thank you for that, because that's important to underline that we do this.
But I think the question is also whether there is a kind of selection bias, right, in terms of the type of the facility.
Right.
Whether there is a creaming of.
Yeah. Oh yeah, right. No, we have we do this kind of balance test that shows that there's some variation, but there is a reasonable balance. If you count for the fact that, for example, there are underlying biases here, right? That for example, in metropolitan areas there are more women, so there would be maybe more women at these facilities and things like this.
But it's also given how the system is designed. It's a kind of, you get a decision where you live. It's like a school in the catchment area where you live and where is the place available. So there is very little kind of room for an individual or for the nursing home to affect this process.
Yeah, and a fixed rate as well. So it's not really supposed to be an economic or financial matter for the individual either, right?
Sure. That's helpful from a modeling perspective, at least.
Yes.
Wonderful. Okay. Well, thank you very much. That was fascinating presentation. Really interesting. Not just about COVID, but also, as has been said, learning more about the differences between systems. So thank you very much, Rasmus and Marina, for a great presentation, and looking forward to the next GOLTC seminar.